Hi everyone, sorry that I can't join you today for the Community of Practice for End of Life Care. So I've been asked to do a bit of a spotlight around the City of Manchester programme for End of Life Care over here in the Northwest. So what I thought I'd do first of all is give you a little bit of the history about what happened and why we've ended up with the City of Manchester project. Or programme, sorry, I'll be in trouble for that. So back in 2014, Mellor Northwest were lucky to get investment of just over £5 million at that time for the Mellor Manchester Cancer Improvement Programme. And that was following research that had shown that there were higher than normal national levels around stage 4 diagnosis for lung and breast cancer across the City of Manchester. In particular, in North Manchester, these numbers were higher and combined with higher than normal rates of poverty, low home ownership and personal transport and poor literacy. So because of that, and also because there was no hospice service available within North Manchester, and we had limited GP practices using the end of life register and the community palliative care service, which consisted of 3 clinical nurse specialists at the time with a very understandably high rate of sickness. The Macmillan Development Manager had been working really closely with the North Clinical Commissioning Group to look at how vulnerable groups could be supported, so that together they formed a partnership to improve end-of-life care for its population. I think it's also important to say that complaints to the CCG in relation to end-of-life care in North Manchester were ongoing, and families were identifying the lack of specialist support and care at end of life, resulting in admission to A&E and people dying within hours of being admitted into the local hospital, which was North Manchester, rather than being able to be cared for at home, which is what they'd requested. A review of the community services identified that within the same building that the community palliative care team were sat in, there was a Macmillan community therapist team. And although they worked independently and had paper referrals that they would require from each other in offices practically next door to each other, that felt very strange and actually felt the wrong thing to happen. North Manchester itself had 4 GP neighbourhoods, which was supported by district nursing teams and other community-based teams. And again, in an area of so many complex social circumstances, the services from the district nurses were extreme. So therefore, lots of patients were being referred to specialist palliative care services that in other circumstances might not have been referred. Following the consultation within the CCG, the community palliative care team, the therapy team, district nurses, patient service user involvement, it was decided that there was a model of care that would be ideal to move forward. So to match the 4 neighbourhoods, they decided that they needed clinical nurse specialists, 4 band 7s, 4 band 6, the introduction of the new role of the palliative care assistant practitioner post, that there needed to be input from the therapist team for across the city, but the therapist team needed to be speech and language therapist, dietitian, occupational therapist and physiotherapist. There was a great need for a consultant in palliative care. There was a GP who had a special interest in palliative care, who from time to time was able to offer support to the team. And also there was a need for a district nurse liaison post, and that was quite an unusual post because that person would be based in the community, would actually go and see people in hospital and make assessments of them and then prepare the district nurses for that person going home. In addition to that, we also had identified the role of a voluntary coordinator a volunteering coordinator who would work with the team and with other agencies who already worked within North Manchester to try and coordinate care for those bits in between where nursing or assistant practitioner or therapy input wasn't required. Administration was really important, and in the second year of the pilot we'd identified within the first year that there was a great need for education. So in the second year we introduced a nurse lead for education within the team. Within the actual MSIP or Manchester Macmillan Cancer Improvement Partnership, we were allocated 3 days a week of a project manager for the whole of that really busy project pilot, which nowadays would be called a programme. And within the CCG allocated a lead, finance and data analyst, and the GP with special interest. So that pilot started, the work started to move forward, and the team started to come together. We needed to move them from the location where they were because it was really unsafe. There were drug addicts using the building during the day and at night. There were rats running around the place. So the team also needed to be relocated. So those aspects sort of slowed down the move of the whole team together into one place for quite a while. But they're the challenges I think that any of us would come across. So we do Evolution Manchester back in 2017, where health and social care came together within the City of Manchester and within North CCG. We then had North CCG and South and Central CCG being able to provide a different standard of end-of-life care. And it was important for equity for what became Manchester CCG, the equity of care for end-of-life care, not just for cancer patients, for anybody with a life-threatening illness, actually was across the city, and that was what they wanted to move towards. So they worked closely with our then strategic partnership manager, Julie Atkin-Ward, and Tanya Humphreys, the programme manager, to actually look at what we could do and how Macmillan could help them through investment to take that team forward. So there was lots of work around what we should do and what we should do differently. So the opportunities for us from that was that we could have a citywide team. So although the teams are based in 3 different localities, the team are responsible for the whole of the city. And the hope in that is that if for some reason one of the localities suddenly had an increased number of sickness within a certain speciality, that the other teams would be able to cross cover. We wanted a 7-day service across the city between the hours of 8 a.m. and 8 p.m. and we needed those specialists to do that, and that was really important. We needed to further develop what was happened at North Manchester. So the use of beds within care homes for palliative care patients that needed maybe some rehabilitation or some respite care. The opportunity to look at what was happening around the use of Marie Curie services and different night services. So we needed to consider those things, but we wanted a citywide approach to that. That's the partnership, not just Macmillan. The further thing that we recognised when we were sort of coming towards the end of the pilot for the North Manchester project was we hadn't evaluated that. You know, there'd been data collected because it was important from day one for the CCG that they had the evidence to get that pilot sustained, which they were really successful, and they did that. But what we hadn't done is what hadn't happened was it hadn't been evaluated, and it was really important that we evaluated that work from day one of the project going citywide. So that was another thing that we looked at, and looking in particular at support of patients for care closer to home, and that those people who wanted to die at home had the opportunity to die at home. It provided an opportunity for everybody, including Macmillan, to learn about service provision and what could be utilised to make service provision better through integration of all services. The key point across both of these, the pilot and the work that we're now currently doing, is engagement with service users. And that's always been an area that people have shied away from before in end-of-life care, because it's always felt wrong to talk to people or the families of patients who are dying or after death to ask them what their experience was. But we've recognised that that's really important, and that was something that we really wanted to do. So service users have been absolutely integral to what we're doing and what will happen in the future. Developing an integrated pathway for end-of-life care across all service communities, and also working with those specialist workforce. You know, there's very close working with drug and alcohol agencies now, homeless agencies, health and social care, you know, social care in particular agencies, housing, all those things have been developed further. What we wanted to do was that for people across the city of Manchester who were diagnosed with a life-threatening illness, was that they could have time, be in an environment with people from the point of that diagnosis, to be able to start to make plans for their end-of-life care as appropriate for them and at the time that was right for them, but also to be able to look after those people and really encourage them to live the best life that they could in that period of time, and be able to be supported by people at the right time and be able to live the life at other times when they didn't need people. Working with voluntary organisations again is crucial and has been crucial to us, and absolutely those organisations have been the people that have been able to go in and do things that healthcare professionals wouldn't be able to justify probably to their managers. So to walk people's dogs, to take people for a haircut, to take somebody to a hospital appointment, you know, the list is endless of the types of things. If somebody's admitted to hospital, I can't tell you how many times in North Manchester a room in a house where that patient's sleeping has been decorated and carpeted and new furniture put in with the help of Macmillan Solutions. So the challenges as we move forward. So the challenges are many, but some of those challenges are the recruitment to specialist palliative care posts across the workforce spectrum. Because as we all know, those post holders are limited, and people who come into those posts tend to stay in those posts and work really hard. But what we need to do is we need to think about how we can do that differently. Palliative care consultants hopefully now are a growing breed, but it's limited the number of palliative care consultants. And all of our services, it is crucial that we have a community-based consultant, because that is one of the things that has made the real difference to the service that was already being provided by Macmillan community end-of-life nurses across the country. 7-day working and hours of work, balancing service user need against the financial restrictions of partner organisations, because we all want to do our very best for people with cancer and other life-threatening diseases. But when a partner organisation has got a finite budget, we might want everything and the cherry on the top, but actually we have to do what we can do with those partner organisations. Definitely defining end-of-life care and life-threatening illness, and when people should be referred to the service and when is the right time for that to happen. Additional pressures that when you suddenly get a great team and that are providing end-of-life care, and they refer on to other services, they start asking social workers and welfare rights officers and district nurses and other groups to come and see those patients and to get involved with them, and their services are probably limited as well. So that's one of the challenges. And the evaluation. So the expectations of what we want and require from Macmillan, but also what our partner organisation wants and needs to be able to move things forward and actually to make these services sustainable for them in the future and be able to grow. The highlights for me are improved care and experience for those who are nearing the end of their life and who have a life-threatening illness. For them, those patients, their carers and their families and people who are important to them. Improved skills of GPs and district nurses. So the district nurses will tell you from North Manchester, just sitting in the 30-minute hub every single day and having the opportunity to share patients with other specialists, to actually have the opportunity for a therapist or a nurse or a consultant to go and review a patient with them in a really timely manner has been a fantastic opportunity and upskilled them to provide care for patients that don't need complex specialist palliative care needs. Staff morale, you know, in any change, it's difficult when new things are happening, but actually to see a team come together and come alive and actually see that there are enough people for that team to provide what they want to provide for patients is absolutely amazing. And I think if they were here, they would agree. The wish to continually improve the service, that's been one of the things for me, that every time I meet up with any of the service managers that now exist, they're telling me about the next thing that needs to be done, the thing that they want to do better, the improvements they're going to make. Service managers with experience of commissioning and delivery of service has absolutely been crucial and one of the key things to move us forward. The nurse educator role, which we hadn't even considered in North Manchester in the work up to the bid and even in the first year, but that post holder is now working with Salford University and they're developing a course for specialist palliative care for people with life-threatening illnesses that's going to be available, which is a fantastic achievement. The ability to make, and more importantly to change care, has also been important. The whole team approach, I think, that from a personal perspective, not enough can be said about the need for an integrated approach to care. The daily hub meetings provide an opportunity for communication of patients' needs, learning and development of individual staff, expert input across all specialities. Working with those outside your speciality to enhance patient care and also developing yourself at the same time to ensure that patients get what they need in a timely fashion. You know, the involvement of the ambulance service and policing services and the complex needs of patients being shared in the right way, in an appropriate way, through all those agencies, allowing patients to get better care whichever area that they live in. Attendance at GP meetings, so for end of life and palliative care register meetings, have developed closer working relationships and have gained an insight into patients' needs and also the needs of that GP practice and the professionals within that GP practice. And everybody's talking the same language, everybody's communicating. The great thing for me is everybody has a voice. Whoever you are in those teams, you've got a voice and you'll be heard. Everybody has a responsibility for the service, and that's really how they feel to me, that everybody knows what they need to do and knows what they need to deliver and don't see themselves as an individual with one speciality, but see themselves as part of the bigger team. Improvement in communication through shared experience, multiple experts in one place and available, and the ongoing innovation and growth of individuals and the service. Excellent end-of-life care with an opportunity for people to live their best life while they can make decisions and also making decisions about end of life care. So just to finish, what I'd like to do is I'd like to share an example with you of a case study that was shared with us about a lady who lived in quite an affluent area in South Manchester, and her relationship with her husband broke down. She had a high profile job. She found a new partner who unfortunately was a drug addict. Within a couple of years, her home had gone. She was living in a squat with this person over in the north side of Manchester. Her personal circumstances were terrible. She was diagnosed with stage 4 lung cancer. She had metastatic disease. She had other complications. Her partner, although when the clinical nurse specialist, when the Mellor clinical nurse specialist got involved with this lady was doubly incontinent at the time and very unwell. Hadn't gone for all of her treatment because that interrupted with what her partner wanted her to do. And tragically, her partner, as well as assisting her to become a drug addict, had used her for prostitution. So when the nurse went to see her, there were men queuing up outside the room that she was in, although this lady was doubly incontinent and her partner was there taking money off them. The relationship that the clinical nurse specialist developed with the patient enabled the clinical nurse specialist to support the patient to actually be admitted to the hospice over in South Manchester, and so that they could review her and they could see what they needed to do and see how they could offer her help and support, which this lady accepted that opportunity. The tragic thing about that was that the nurse had organised an ambulance to come and collect this lady, and while the ambulance was outside the squat waiting for this lady was running up and down the road trying to find clients because her partner had told her that he had no money and he needed her to get him some money before she went. She was admitted to the hospice. She was looked after in the hospice, and unfortunately the partner came to the hospice and managed to talk this lady into leaving the hospice and took the lady back to the squat again, where this man had clients waiting to have sex with this lady again. It's unbelievable, isn't it? It's unbearable for us to think. The clinical nurse specialist didn't give up. She went back to see this patient. She talked to this patient. She supported her. She liaised with the hospice and asked the hospice to take this lady back. And after a little while, the hospice were able to offer this lady a bed. The lady accepted the bed. And part of that whole relationship, this lady had lost contact with her only daughter because of her circumstances. And through the help of the clinical nurse specialist, this lady and her daughter in the last few days of her life were able to reconnect and have some sort of relationship at the end of this lady's life. So for me, that is the amazing thing about us having the opportunity to do the work that we're doing in the city of Manchester.